The unwanted snack. Today, we are talking about one of the most common and potentially deadly emergencies you will face in general practice: gastrointestinal foreign bodies. Defined simply, a GIF-B occurs when a dog or cat ingests a non-food object that gets lodged anywhere along the tract, from the esophagus down to the colon. While we often joke about dogs eating homework or socks, the pathophysiology here is serious. An obstruction stops being funny the moment it compromises blood flow. The pressure on the intestinal wall leads to necrosis, perforation, and ultimately a septic abdomen. If we don't recognize and intervene quickly, these patients can die from sepsis. Clinically, we see a distinct divide between our patients. Dogs are the indiscriminate vacuum cleaners. They tend to ingest discrete, large, non-digestible objects like rocks, toys, corn cobs, or clothing. Cats, on the other hand, are more precise but equally dangerous in their habits. They are the poster children for linear foreign bodies. They are fascinated by string, yarn, tinsel, and ribbon. These objects often anchor under the tongue while the rest travels downstream, causing the intestine to bunch up or plicate like an accordion, which can slice through the mesenteric border like a cheese wire. Whether it is a Great Dane with a tennis ball or a tabby with a sewing needle, quick recognition is critical to preventing disaster.
So, what actually happens physiologically when an object gets stuck? It starts with luminal obstruction. The foreign body blocks the flow, causing fluid and gas to back up upstream, oral to the blockage. This distension is what triggers the severe pain and vomiting. But the real danger is silent. As that intestinal wall stretches, the pressure cuts off blood flow to the tissue. This tissue hypoxia leads to necrosis, weakening the wall and setting the stage for a rupture. Now, let's talk about the nightmare scenario: linear foreign bodies. This is classic in cats. One end of the string anchors, usually under the tongue or at the pylorus, while the rest travels down the intestine. Peristalsis tries to push the string, but because it's anchored, the intestine climbs up the string instead. This creates plication, an accordion-like folding of the bowel. The tension pulls the string tight against the mesenteric border, acting like a cheese wire that can saw through the tissue, causing multiple perforations along the entire length of the tract. This brings us to perforation, the worst-case outcome. Whether from a sharp object or chronic pressure necrosis, once the wall is breached, bacteria and GI contents leak into the abdomen. This causes septic peritonitis, leading to a rapid decline into septic shock. At this point, mortality skyrockets without immediate surgical intervention. Who is our typical patient? In dogs, it's usually the young and dumb. Young, active dogs, especially sporting and working breeds like Labradors, who are high-drive chewers. Dogs with access to trash or household debris are essentially walking time bombs. For cats, the demographic shifts slightly. We see this in playful kittens who accidentally ingest string toys, but also in adult cats with pica, the urge to eat non-food items. Keep an eye out for cats in multi-cat households or stressful environments, as stress-related pica can drive them to obsessively chew on fabrics or cords.
Diagnosing a foreign body often starts with the history, but the clinical signs tell you the urgency. The hallmark sign, of course, is vomiting. This can be acute and explosive if the obstruction is high, like in the pylorus, or intermittent and chronic if the object is moving or lower down. You will also see the classic sick dog signs: anorexia, lethargy, and dehydration. Pay close attention to abdominal pain. In dogs, we see the prayer position again, stretching out to relieve tension. But there is a critical distinction to make. Is the patient vomiting or regurgitating? If you see regurgitation, passive expulsion of food or saliva without heaving, stop looking at the stomach and start looking at the esophagus. An esophageal foreign body requires a completely different approach. Linear foreign bodies have their own specific red flags. In cats, this often presents as repeated, relentless vomiting. Here is the most important clinical pearl of this episode. Always check under the tongue. In cats, string often anchors around the base of the tongue. If you miss this during your oral exam, you might miss the diagnosis entirely until it's too late. On palpation, these patients are often extremely painful due to that cheese wire tension we discussed. Finally, you need to recognize the signs of perforation and shock. These patients are crashing. They present with collapse, pale mucous membranes, and tachycardia. They may be febrile initially due to sepsis or hypothermic if they are in decompensated shock. Their abdomens are often distended and fluid-filled. If you see these signs, you aren't just diagnosing a foreign body, you are managing a septic abdomen, and you have minutes, not hours, to act.
Diagnosis begins with your hands. On the physical exam, you are palpating for a tense, painful abdomen. In some lucky cases, you might actually feel the foreign body itself, or in cats with linear bodies, you might feel a distinct bunching of the intestines, almost like a cluster of grapes. Check under the cat's tongue. If you see a string anchored there, do not pull it. Radiographs, X-rays, are our first line of defense. We are looking for a visible, radio-opaque object like a rock or a coin. But often, the object is invisible, radiolucent. In those cases, we look for the two populations sign. This is where one segment of the intestine is massive and gas-filled, oral to the blockage, while the rest is empty and collapsed. If you see free gas in the abdomen, that indicates perforation.
When X-rays are ambiguous, ultrasound is the problem solver. It is excellent for finding those non-radio-opaque objects, like corn cobs or toys, and is superior for diagnosing linear foreign bodies. The ultrasound will clearly show the plication of the intestines and can often identify free fluid, suggesting peritonitis. Endoscopy has a specific, limited role. It is fantastic for esophageal and gastric foreign bodies. Grabbing a bone out of the stomach before it moves downstream is the ideal scenario. However, it is generally not appropriate for linear foreign bodies due to the risk of sawing through the tissue during removal or for objects that have already passed the pylorus into the jejunum. Finally, don't ignore the blood work. It tells you how stable the patient is for anesthesia. The classic finding in a vomiting dog is hypochloremic metabolic alkalosis. They are losing acid and chloride in the vomit. You will often see azotemia from dehydration and elevated WBCs from stress or infection. If you see a high lactate, worry. That suggests tissue necrosis or septic shock.
Once the diagnosis is confirmed, we move to treatment. But before we even think about anesthesia, we have to talk about stabilization. You cannot perform successful surgery on a patient in shock. We need to aggressively rehydrate with IV fluids, correct those electrolyte imbalances, and get pain management, usually opioids, on board immediately. We also start antiemetics like meropitant or ondansetron to stop the fluid loss. Here is a critical do not do rule. Never give prokinetics, like metoclopramide, to an obstructed patient. If there is a blockage, giving a drug that forces the gut to contract is like pushing a car into a brick wall. You will cause a rupture. Now, how do we get the object out? If we catch it early and it's still in the esophagus or stomach, we might get lucky with endoscopy. This is the ideal scenario. Grabbing the object with a scope means no incision and a very fast recovery. However, most cases require surgical intervention. Gastrotomy. If the object is in the stomach, we cut into the stomach wall. This is a robust, forgiving organ with a great blood supply, so this is a relatively low-risk procedure. Enterotomy. If the object has moved into the intestines, we perform an enterotomy. We make a longitudinal incision downstream from the obstruction, in healthy tissue, to extract the item. Resection and anastomosis, or R and A. This is the heavy lifting. If the intestine is necrotic, purple, or perforated, we cannot leave it. We have to remove that dead segment and sew the healthy ends back together. This carries a higher risk of dehiscence, or leaking, but is life-saving. Finally, a special rule for linear foreign bodies. Never pull the string. If you pull, you act as the saw. Instead, we surgically release the anchor point, under the tongue or at the pylorus, and then carefully remove the string, often requiring multiple enterotomies to feed it out gently without slicing the tissue.
The surgery is done. Post-operative care is just as critical as the procedure itself. Our primary focus is monitoring. We need to maintain aggressive hydration and electrolyte correction, as many of these patients are still recovering from the metabolic toll of the obstruction. Pain control is also essential, not just for ethics, but because pain slows down gut motility, which is exactly what we don't want. When it comes to feeding, the old rule of starving the patient is out. Unless there was massive contamination or shock, start early, small, bland meals as soon as the pet is awake and alert. Nutrients in the lumen actually fuel the enterocytes and speed up healing. Do not send every foreign body home on antibiotics, only in case of peritonitis and perforation.